All right, welcome to this explainer on hereditary spherocytosis. Whether you're on the wards or deep in exam prep, this is the high-yield overview you need to really nail down your clinical understanding. Let's get right into it. First off, a really important credit. This entire clinical summary is credited to Dr. Mohammed El-Nagi Mohammed. So, here's our game plan. We're going to start with a quick overview, then we'll break down the pathophysiology. After that, we'll look at the clinical signs, walk through the modern diagnostic pathway, and wrap up with the key management strategies. Okay, let's kick things off with the basics. What exactly is hereditary spherocytosis, and why is it so important to have on your clinical radar? So, at its core, hereditary spherocytosis, or HS for short, is an inherited condition that causes a specific type of anemia called hemolytic anemia. It's most common in people of Northern European descent, and the name gives it all away. The main problem is that the red blood cells are produced as these abnormal spheres. So, how does this actually happen? Why do these red blood cells change shape? Let's dive into the pathophysiology to see how one tiny genetic flaw leads to this cascade of cell destruction. Okay, this slide lays out the whole story perfectly. It all starts with a genetic mutation, usually autosomal dominant. This mutation messes with proteins like spectrin that are basically the scaffolding of the red blood cell's cytoskeleton. Without that internal support, the cell can't hold its normal, flexible biconcave shape, and it collapses into a rigid little sphere. Now, here's the real problem. That rigid sphere can't squeeze and deform like a normal red cell can. So when it gets to the spleen, it gets stuck in these super narrow passages. And what happens when it gets stuck? It's engulfed and destroyed by macrophages. And since this destruction happens outside the blood vessels, in the spleen, we call it extravascular hemolysis. Once you get that pathophysiology, the clinical picture makes so much more sense. So what are you going to see when a patient with HS walks through the door? Well, these signs are all a direct consequence of those red cells being destroyed. You'll often see jaundice because of all the hemoglobin being broken down. You'll see splenomegaly, an enlarged spleen, because it's working overtime clearing out all those defective cells. This can also lead to pigment gallstones. And in kids, you might see a failure to thrive. The severity of the hemolysis can really vary from person to person. Okay, this next point is absolutely crucial, especially for your exams. The aplastic crisis. See, these patients already have their bone marrow working in overdrive to keep up with the hemolysis. If they get an infection with parvovirus B19, which loves to attack red cell precursors, it can completely shut down red cell production. That causes a sudden, catastrophic drop in hemoglobin, and it's a true medical emergency. Now, let's look at the labs. One of the classic telltale signs you'll see is a raised MCHC, or mean corpuscular hemoglobin concentration. Think about it. The cell loses some of its surface membrane and becomes smaller, but it keeps all of its hemoglobin. So the concentration of hemoglobin inside that smaller sphere is actually higher than normal. It's a real hallmark of spherocytosis. Okay, so we have a strong suspicion. How do we actually nail down the diagnosis? Let's walk through the modern, guideline-based approach. This is a really important update for anyone in clinical practice. The classic test you might have learned about, the osmotic fragility test, is actually not recommended anymore. It's just not reliable enough. The current British Journal of Hematology guidelines point us towards much more specific tests, like the EMA binding test or the cryohemolysis test, for when we really need to confirm things. And this quote really drives home a key point in modern medicine. The guidelines are clear. If you have a patient with a family history of HS, they've got the typical clinical signs, and the basic labs fit the picture, you don't need to do any fancy additional tests. The diagnosis is already made. So let's just quickly recap that diagnostic strategy. For your straightforward, typical case, the clinical picture and the labs are enough. But if things are a bit murky, if you're not 100% sure, that's when you reach for the EMA binding test or the cryohemolysis test. And in those really tough, atypical cases, the gold standard becomes electrophoresis to directly analyze the red cell membrane proteins. All right, let's bring it all together in our final section, management. How are we going to treat these patients? You can really think about management in two buckets. During an acute crisis, whether it's hemolytic or aplastic, the care is mostly supportive. You might need to give a blood transfusion if the anemia gets really bad. Long-term, though, folate replacement is key because that high cell turnover chews through folate stores. And then there's the big one, splenectomy, which can essentially cure the hemolysis because you're removing the very place where the red cells are being destroyed. And this brings us to the big clinical dilemma,
the question you'll have to weigh for your patient. A splenectomy can be a total game changer, but it's not without its own lifelong risks, especially the risk of overwhelming sepsis. So the question you always have to come back to is this. For this specific patient in front of you, when does the benefit of stopping the hemolysis truly outweigh that risk? That's a decision that takes real clinical judgment, and it's the perfect thought to end on.